for letting. Feel free to, this is really for you guys. If you have any questions, feel free to interrupt and ask me. The title they gave me was Instruments and Gadgets Regarding Prostate Cancer. So I thought that what I would talk about are how we treat with instruments and gadgets some of the more common complications that we see as a result of our prostate cancer treatments, whether it be surgery or radiation. So I hope that'll be interesting for you guys. I hope I can give you some helpful hints. And we'll just keep it very informal. So I wanted to start by talking about erectile dysfunction, which is something that we unfortunately see a lot of after our treatments. Okay, let's see if I can figure this out. Okay, so just to make sure everybody understands how we look at erectile dysfunction and how we think about treating it, I'll go over some of the basics. When we say erectile dysfunction, we're really talking more about difficulty getting and maintaining an erection. And there's a whole nother area of sexual desire and libido that we work on as well. And that often involves your testosterone, what medications you're taking. But the main area today we're going to talk about is just able to have a sufficient erection for penetration. And it's unfortunately a very common thing. And it's obviously age dependent, but I have to say that probably half the male patients over a certain age do have it. And it's, it's not just from prostate cancer, it's from all kinds of things, medications, neurological diseases. But what we see a lot of, because we're urologists, are the guys who have problems after prostate cancer treatments. Okay. So just to go over some of the anatomy, I don't have a laser pointer, so excuse me if I point too much, but I think you all know the difference between flaccid and erect, I would hope. And obviously the erection makes it easier for penetration, but this is the a cross section through the penis. And the bottom part here is what we call the urethra, and that's where the urine comes through. And this particular part is really not involved in erections. That's the urination mechanism. So the main bulk of the penis is composed of two large chambers on the left and the right side, and these are called erectile bodies, or medically known as corpora cavernosa. And they're a distinct type of tissue, which is why medicines like Viagra work primarily on the penis, because they're tissues that are very spongy, and with the right stimulation, blood will come pouring in and the spaces will open up, and it can sort of like get very filled with blood and engorge, and that's why they call it erectile tissue. So for a normal erection, it takes about 8 times the volume of blood that is normally circulating through the penis to go in. So that's why, if you don't get this extreme increase in the amount of blood that you get in there, you're not going to have a good erection. And the other thing about erections that's interesting is that when there's a mechanism that when this tissue gets filled with blood, these erectile bodies, it squeezes this big blue thing up here, which is the main vein that drains the blood from the penis. And that's how the blood stays there. It's called, it compresses all the veins. So for a normal erection, you not only have to have an increase in blood flow, but you have to have the veins get shut off, which is the normal mechanism.
I think question.
Yeah.
Can low blood pressure contribute to erectile dysfunction?
Yeah, definitely. In fact, that's the reason why a lot of fellows who are on antihypertensive medicines have problems, because the blood pressure medicines will lower the blood pressure, which is a good thing, because it's good for your heart and prevents strokes. But on the other hand, it can lower it so much that you don't get enough force of blood in there. And that's a major complication that we see of antihypertensive medications. Yes. So just to give you an idea, there's all different causes. We see after pelvic surgery, after radiation, in a smaller percentage of patients, but medication can do it. They say 15%. I think it's even higher. Diabetes very commonly will affect erections. Diabetes affects both the nerves and the blood vessels. So you can have erectile dysfunction on the basis of nerve damage or blood vessel damage. And the big thing we see in men, and this is after prostate cancer radiation or surgery or just from aging, and you know what arteriosclerosis is, the arteries get narrowed, you get a high cholesterol. That's a big thing when in many fellows as they get older, the arteries, the same arteries that get blocked in your heart and that causes heart attacks, they get blocked in the penis. And it doesn't cause a penis attack, but it causes a lack of erections. So this is basically our analogy to what a heart attack is. You just don't get quite that blood flow in there. And diseases like Parkinson's, strokes, multiple sclerosis, ALS, anything that affects the nerves, it prevents the proper signal to get the erection going in. And that can be a cause of erectile dysfunction. So, and specifically with what we do with the prostate, this is sort of a slide that shows what we do, how the prostate is related to the nerves and blood vessels. You know, the prostate is a gland that produces a lot of the stuff in the semen. The bladder stores the urine, and there's a tube called the urethra, goes right through the prostate, and it comes out the penis on this end. So what is drawn in yellow here are the nerves, and well, we're the blood vessels too, but they're showing the nerves. The nerves that run to the penis that give the right signal to allow blood to come in are very close to the prostate. So even in the best of hands, when we cut the prostate out and we want to remove the whole thing because we're getting rid of the cancer, it's very often that we damage the nerves, unfortunately, and the blood vessels for that matter. So that's why, unfortunately, many fellows after radical prostatectomy, the operation we do to remove for cancer, have erectile dysfunction. And what's interesting is that it's very age dependent. You know, if you're a guy who's 50 years old and you have surgery, you're probably going to have your erections intact. If you have that same surgeon, the same operation, and you're 75 years old, you're much less likely. So there's obviously, in every case, there's some damage to these nerves, but in younger fellows, the ability to regenerate is there to some degree, or else they have more, spare blood flow that they can make use of with some damage. Yes,
Is there
sir.
any place for nitrates to regenerate the artery?
You mean oral nitrates? Well, unfortunately, the nitrates that are usually out there, like L-arginine and stuff like that, that are precursors, they tend to not survive when they're taken in pill form. You know, the only real data that I'm aware of that shows nitrates work in a practical sense is when they're given intravenously. So all the supplements that have it, I really find don't work well because they're broken down so much by the body. It's a good thought, but that's, I think, why they don't work. And this just shows after the prostate's removed, we hook up the bladder to the urethra, and hopefully these nerves are intact. But again, even in the best of hands, they tend to get damaged. Now, the robotic surgery has been a big advance with the robot, and I don't do the robotic surgery myself, but my two partners, Carrie and Catherine, do a lot of them. They can have such good magnification, and there's no bleeding because there's increased air pressure, so they can see really well. So I think our guys nowadays are doing as well as ever in terms of not having erectile damage. Okay. So just pretty much says what we were talking about. Now, whether you have surgery or radiation, which, I mean, there are other treatments for prostate cancer, as you guys all well know, but the two most common ones by far that we do are surgery and radiation. There's other things like HIFU, there's new laser interstitial therapy, there's cryosurgery, but I'd say 80% of our treatments are either radiation or surgery. And I would say that it's very, age dependent, but overall, probably about half of men are affected. It's also helpful if a guy has good erections before surgery, he's much more likely to maintain them afterwards. But, there's a significant risk of losing erections after these treatments. Doesn't mean we can't help it with what comes up next, but it is definitely a big risk. So I'm going to talk about different treatment options here. And there's one more I'm going to talk about that's very interesting that a gentleman over there on the name asked me about. So when I help fellows with erectile dysfunction, the way I look at it, these are the easier ones, and these are them as you go across. So these are not quite in order, but I try the easiest things first, things that are the least invasive things. And it goes from just giving oral medications to the other end of the spectrum, which is teaching men injections or even having penile implants. Now, one thing that's not on the slide, because this is a very new treatment, have you guys heard of low intensity shockwave lithotripsy for penile erections? Yeah, that's what you showed me. The medical term is called LI-SWL.
$3,000.
Yeah, well, I'm going to talk about that.
It works, I'll pay.
For years, we've been doing a procedure called lithotripsy, which involves shock waves to break up kidney stones. It's based upon German sonar technology. So in the past few years, it's shock waves, energy waves that when you focus on a stone, it breaks up stones. So in the past few years, some people have done studies where the whole idea is they do shock waves on the penis in men with erectile dysfunction. And the theory of this, which has been proven in animal studies, is it causes regeneration of some of the blood vessels that have been damaged by aging. It actually shows regeneration of what they're called endothelial cells. So the bottom line is it's currently being offered in certain places now. I think there's one place in Sarasota, not my group, that's doing it. I know there's a group in Tampa, there's a group in Lakewood Ranch. The long-term data on it is really not out yet. So no one really can honestly tell you, is it going to work for the rest of your life? There's short-term data in several studies shows that if you look at 3 months and 6 month, 6 months, rates of success, that it does help a fair number of people. The studies are positive. Right now, because it's considered experimental, no insurance or Medicare will pay for it. It's probably, I've heard as low as $2,000. I don't know, did you say it was $5,000 in your group? Was
they would sell so big
$3,000. Yeah, I know another patient told me $2,000. And it's a treatment where you go in once a week, usually for a few weeks. They just hook up this thing around your penis. It's pretty much painless. You may feel a little bit of pinging in your penis, but nothing bad. And you blasted for 20 minutes. So again, this is the way I would leave this. I mean, I've read a whole bunch of studies on this. They really are promising. So I don't want to poo-poo this as something that's just a money-making scheme. I'm part of the hospital group. They're very conservative until things are approved by Medicare and insurances. They don't like us to do things because they feel we're scamming patients. It may not be a great thing in the long run. I keep all your eyes and ears open, and I hope in a year or two, there's good data and Medicare will pick it up because it's a very nice non-invasive treatment that can be offered. But I just don't have, in animals, it seems to really, when they do studies, it seems to make changes in the tissue that are positive, and that's why I think it has potential.
What's the name of it again?
Well, the technical term, if you want to look in the medical literature, is LI, low intensity SWL, shockwave lithotripsy. I think this gentleman's folder, what do they call it? Something a little bit different, you said?
Anyway, I could pass it around, Jeff, if you want.
Yeah. So anyway, it definitely has potential. So let me talk about some of the other treatments. Now, everything here is pretty much that are invasive are covered. You all know about Viagra. There's several medications. They're all pretty much the same. They're in the same real family. They all work by the same mechanism. They're called Viagra. They're called Levitra. There's one called Statin. There's one called Cialis, which is also known as Tadalafil. So Cialis has a longer mechanism of action, so it's good for 36 hours. So if you don't know exactly when you're going to do it, it has more flexibility for you. On the other hand, if it causes a headache, you'll get a headache for longer. So that's the pros and cons of that particular drug. I actually like Viagra more because most people realistically know when they're going to fool around. And the Viagra, I think, works a little more effective. And if you do get a side effect like a headache or you feel flush, it's only going to be for a few hours. These medicines are generally very safe. If you're on nitroglycerin pills for your heart, or if you run a low blood pressure, then I wouldn't take it. But for most men, unless you have those problems, even if you have heart disease, as long as you're stable and not taking a nitroglycerin pill, they're very safe. They don't work for everybody. They work probably half the time, 60% of the time. And if they work for you, great. Unfortunately, although several of them have become generic, Viagra is generic, Cialis is generic, they are very expensive. If you go to your typical Walmart or CVS, how much do you think it's going to cost you a pill? Maybe some of you know. Yeah, right.
$2 to $10, depending on where you go.
Well, yeah, if you go to the pharmacies like Walgreens or CVS, it's about 30 or 40 bucks a pill, even though they're generic. We have a place in town that's a discount pharmacy. People get them from Canada, and it's much cheaper. You know, if you buy 30, you can get them for $7 or $8 a pill usually. Yes, sir.
There's a place in Port Charles that if you have GoodRx Gold,
Mm-hmm.
it's $34 per month.
It's good. That's a great deal. Yeah. Yes, sir.
I found a place on Bee Ridge up by McIntosh where they sell those tiny little ones.
Sildenafil, probably.
Yeah.
Yeah.
Sildenafil, and
Right.
basically you take 5.
Right.
Tiny little ones.
The-
They sell them for $2.
Right. That's the sildenafil is the generic compound in Viagra. It's been used for years to help babies who have a problem with their heart. And they also found the babies all got erections. So that's how Viagra started. Seriously. That's how Viagra started. So if you take 5 of them, because they're in small doses for little babies, it'll do the same thing as Viagra, because it really is Viagra. Yes, sir.
Yeah, I got those from Canada, the place. But what I was told by my doctor, well, first of all, I went to New York for my surgery.
Mm-hmm.
And I supposedly had a great doctor. It was the head guy at where I told
Right.
went out a while, and I took advantage of the connection I had. And the first thing he told me after surgery was he doesn't believe in the pills, which, you know, I said, okay, you know, I was right after surgery. And my doctor here that's watching me since I live in Sarasota, he told me to take this Tadalafil or whatever. and
Sildenafil.
Do this thing to pump. It's the reason is to stop shrinkage for amongst French men. So, you know, because he says that the prostate gets going to start shrinking a little bit. And so that's what I've been doing, and I think it's going okay.
Yeah, most people.
But, you know, I was freaked out a little bit by the fact that this top surgeon in New York, best hospital in the country, told me that he doesn't believe in pills. And, you know, what I'm doing
I don't
is
agree
I
with
was
that.
operated, well, yeah,
Yeah.
I was operated on in June, so I'm just trying to have patience and wait things out before I start.
Yeah.
With all these I'm hoping, maybe I can come back. Because he said that he saved my nerves, but most doctors who do this procedure, the robotics, will say they saved the nerves. But
Well,
I'm having a lot of trouble, I ain't what I used to be. You save my nerves, but I still can't get it up. Let's put it that way.
Yeah, but you have to give it really 9 months to a year before you really
Well,
know.
I'm in that space now because I was
Sure.
operated on in June, so I am trying to be patient, but
Mhm.
I'm starting to run out of patience.
Yes, sir. Yeah.
One of the things, I had nerves spare, but they forgot to tell my nerves that they were spare.
It's
I forgot to tell you nerves, okay.
I had this done 10, 11 years ago. And they found out that the robotic pinchers were exerting a little bit too much pressure, and they were removing or spacing out the nerve runners, and they wanted to push it. But one of the things that I have learned, and I'm just going to pass on to you, will be a warm bath, a glass of wine, seems to just reduce the anxiety of performance and bringing blood in. It may not give you will never be what you want, I'm going to tell you straight up front. But it has, and I've done everything but the
Shockwave
needles.
therapy.
Yeah,
Oh, the needles.
I had one of your partners, and he said it doesn't hurt. So I said, well, drop trowel and stick it in yours. If you don't flinch, I will then go on. He declined when I went off.
I have done it once just to see what it felt like.
And,
It hurt a little bit. I mean, I felt it. It wasn't torture, but I
yeah,
felt it.
but again, you know, everybody says something doesn't hurt because they've never done it to themselves.
Yeah, that's true.
Okay? And I was concerned with Peyronie's disease. I still tell people to be careful where they're injecting. Only because I think if you keep going to the same sites, you're going to wind up heavy.
Right, you should definitely rotate your sites. And I always teach people with either a 20 gauge or a 30 gauge needle, which are very, very small. But there is, obviously it's a needle, you're gonna feel something.
I was quite surprised to see that they still offer these.
That's just an old issue. It's not really offered. I was gonna mention that.
What was that?
There's a drug about 150 years ago before Viagra, which was called Muse. And Muse was, you had on the fourth panel.
It doesn't work well, to be honest.
Yeah.
It's just
It
there.
was the only thing they had way back when. But way back when. I hope it is, I don't know, you never can revisit it, but I can just say one of the.
Sure.
And that is, everybody's physiology is different. And you could have the best surgeon do 10 people who exhibit the same, similar PSAs in Gleason, and you're gonna have 10 different outcomes, okay? So somebody can tell you what the odds are, but if the odds are 80% that everybody's gonna get this, and only 20% of the people are gonna have issues, if you happen to be in that 20% or in that 10%, that's your world. Okay? And I think, quite frankly, most urologists that do any kind of radical prostatectomy are overly optimistic
They are. Yeah.
on what you can expect coming back. And I had my surgery done 11 years ago. Okay. They will always say, you'll get back 60 to 80%. I've been running a group for 8 years. Anybody who's ever had a radical prostatectomy, I have never found anybody who was truthful that said they're at that 60 to 80%.
Yeah, but in all fairness to urologists, one of the treatments that's been emerging more and more is active surveillance. And that's gone up a lot in the last few years. And one of the reasons is because we recognize that there are complications and there are some men that don't need the surgery.
And quite frankly, risk reward is very important. But I was at Gleason 6 when I was cut. And now that you have genetics and genomic testing, I think there's reason to be a lot more optimistic of doing active surveillance.
And that's why the numbers have gone way up with that in the last few years. Absolutely.
I think it keeps a man longer. And one of the things that people who have never had a radical prostatectomy or any kind of treatment is that you only know what your loss is after the fact. Okay? And I think a lot of us that have been living a decade or 5 years or whatever would have probably liked to have had the option that we have today of really identifying what our risk reward is. Excuse me.
No, it's okay. Yes, sir.
I'm just going to observe, because we've talked about it in my group before, that I understand from the doctor's end, it's all the mechanics. But from a woman's end of it, and it should be for men as well, it should be the emotional or emotive side that is of equal or greater importance. In other words, how are you going to satisfy yourself emotionally and your wife or companion should be the bigger issue. I don't see doctors talking about that at all.
Yeah, we don't. Yeah.
And there should be some close cooperation if you ask me, urologists and sexual counselors, of whom there are at least 4 in town. I'm not saying we should give them our business. That's pricey and out of pocket. But it's something that really needs to be brought into the picture well in advance of whatever decision is made.
I think the main impediment is just what you said. It's not covered by insurance and it's very expensive. So, and typically it can't be solved in one, half-hour visit. So it's going to cost folks, $1,000 or $500. And that's probably, it's a good idea, but that's probably the main impediment.
Perhaps, and this is, I'll put it out there now that you mentioned it, perhaps an organization of 3 or 4 doctors, such as your practice, could invite a sex therapist on your dime in a group setting, just a few times, more informative than necessarily therapy per se.
If they would come, we would do that if they would come.
And it could be, again, as a public service to your patients. Something to think about.
Yeah, it's not a bad idea. All right, so vacuum erection devices, these are I don't think they're great. They're very simple. They look like a can of tennis balls, and you put it over your penis. It creates a vacuum, sucks blood into your penis. Take it off. It leaves a ring on the base of the penis, usually covered by Medicare. Very mechanical. Some people want the simplest thing that'll work, and it usually will work. There's no dangerous side effects. It causes bruising or minor discomfort. You don't want to fall asleep with the ring on your penis if you're a little bit drunk, but apart from that, it's very safe and works well. I mean, but not, it works well in terms of giving an erection. I don't think people are satisfied with it because it's very mechanical. These are no longer, they just didn't work. It was actually a nice idea. Instead of giving an injection in the penis, which is what we commonly do, you put a little suppository that's a blood vessel dilator inside the opening where your urine comes out. It would get absorbed and supposedly give an erection, but unfortunately, it just don't work very well. So I hadn't written a script for this probably in 2 years. This is what we commonly do unless we do an implant, and this is called self-injection therapy. I think it's easy for patients to do. Obviously, it's intrusive, and people have to be willing to put a needle in there. We do recommend it with the smallest possible needle. I agree with this gentleman. You do feel some pain, but it's usually for most people very transient and little. The way I look at it, it's the same size needle that a diabetic person would use to give themselves insulin 4 times a day, which they do all the time. So there is a stigma putting it in your penis, but it works for most people, even when the medicines by mouth don't work. I use what's called the triple mix because I find that when you use 3 medicines together, they are much more successful. And it's frustrating to try it and not have it work. But there's what I call a triple mix. It has 3 medicines, which are all blood vessel dilators. One is piperacillin, one is phentolamine, and one is prostaglandin E1. I give people 1 session where I teach them to do it, and most of the time they can do it after that. This stuff is not available at a regular pharmacy. It's a compounding pharmacy only. It's probably averages about $15, maybe $20 a shot, which by today's standards is not terrible. You keep it in your freezer. It gets thawed out when you want to use it, and then you keep it in your refrigerator for probably good for 6 to 8 weeks. Very few problems with it. Priapism, where the erection can last too long, can be a problem rarely. It's usually in our very younger patients. It happens very rarely in gentlemen who've had prostate surgery or radiation. Apart from that, it can make you sore, you can have a little bit of bleeding, but most people get pretty slick at it. And really, although it's a nuisance, it does for many men produce a decent erection. So that's probably the most common thing that our fellows do when they're really motivated.
I don't know how much the dosage.
There's a standard dosage that most of us start with, and it can be up some, but that's, it depends on the patient too. Folks who've had prostate surgery or have had radiation are going to need more because there's more damage to the nerves and blood vessels. So there's a pretty standard dose that we start with, which with the triple mix is a pretty powerful dose. So
Yeah, I was in the doctor's office, said, "You got it." He gave me the shot, and yeah, it was a little painful. And I was in there with my wife, and he didn't know how much to really give me, so it worked a little bit, but that's where I wanted to work. I went home.
yeah, well, I know your doctor is very
And on
conservative.
the
I
next
know.
way I come in, my wife was supposed to do it. I just didn't do it. He left us alone for 5 minutes. But I'm not against it, and I'm certainly maybe in the future I'll try it, but I just wasn't in the mood to.
Yeah, well, if you had only the single drug, you would probably do much better with the triple mixture.
Okay.
Sure.
Does this increase the blood flow? Is that what the drug does?
Yeah, it does. It really does. And sometimes if you do it regularly, it can actually improve the blood flow. And what someone said earlier is true. Nowadays, when you have radical prostatectomy, we do ask people to try to do this soon afterwards, or some kind of technique to stimulate your penis. Some men will use a vacuum pump. Some men will use injection therapy because, the penis is like a muscle. If you don't use it, you lose it. So by regularly exercising it, so to speak, where you're stimulating it, you help get the blood flow back in place. Okay, now we'll talk about penile implants. Penile implants still have a big role. I usually reserve them for men who other things have failed. Ashley was very kind enough to bring stuff in from Haley. I'm sorry, Haley brought some stuff in from AMS, and we can actually pass it around. I can show you guys how they work. They work well for many men. Many men are very happy with them. It is an operation. It's done as usually on an outpatient basis. And the devices nowadays are called inflatable devices. You know, in the old days, it was just a rod. You bent it up when you wanted to have sex. When you're done, you just bent it down. And men were obviously not thrilled with this because you're always walking around with half a heart on. And that was just not satisfactory. The new devices, because they're inflatable, when you want to have an erection, you pump a little pump in the scrotum, which is concealed next to your testicle. And that transfers fluid from a reservoir that's placed under the abdomen into these two cylinders. Your penis will get nice and erect, and it really gives a nice erection. And then when you're done, you hit this pump a different way, and that will transfer the fluid out of your penis. And then it'll almost be like a normal penis. I mean, it'll look a little different because these cylinders are long, but you want to pass it around? That'd be great.
So how long has this procedure been installed in doctors?
They've gotten better over the years, just like everything else gets newer models. You know, we have an iPhone 10 nowadays, and it's the same principle with these. These have been around since I think the first model was probably around 1985 or so.
Well, I saw the little pump in the fluid and all that, you know.
Right.
The first thing that came to me was the breast implants, how they are ruptured in that. I mean, what is the situation with this fluid?
Right, that's a good point.
What is the fluid? Is it ruptured?
Well, those were all silicone. The outer part of this is silicone, but they're not. They're filled with just salt water. There's no silicone that's going to leak out. So the outer part is just. I mean, there's silicone on the actual outside, isn't it still?
Yes.
Yeah. So there's silicone in them, but it doesn't have the I think the breast implants had a problem because it was silicone gel that leaked out. And these are saline inside, so there's no silicone that's going to leak out.
And how long does a procedure like this take to have installed?
The actual surgery?
Yeah.
Probably about an hour, hour and a half in good hands.
And then how long?
And you're sore for, you're sore for a week or two, sometimes 3. And it's not serious pain, but you're sore. Your penis is swollen, black and blue, and you're sore. The implant has to heal before you can use it. So most folks will wait 4 to 6 weeks before you can start using it.
And does insurance cover any of this?
They generally cover it, especially if you've had radical prostatectomy or radiation, or you're diabetic or hypertension, it'll almost always be covered. Yes.
Medicare too.
Yes, Medicare too.
I have a question. We're talking about getting erections, because I get to hear me talk about receiving pleasure from it.
Well, with this device, men will get much pleasure with it. Now, they do say it feels a little bit different because it is a foreign body in your penis. So when you talk to patients, my gestalt is they say, it feels a little bit different, but it's very pleasurable. And you're going to have an orgasm just like before. You're not going to ejaculate because all the stuff that makes the ejaculate is gone if you've had your prostate and seminal vesicles removed. But most men will say, although it feels a little different, it's very pleasurable. And so that part of it is usually there. Yes.
Yeah, we've had 2 of our members who I wish had come today because they both speak very, very favorably about just what the doctor said. That is, the experience is terrific and they're very satisfied with it. Very, very manageable, very, very natural feeling.
And there's really no stress with it because you know that you're going to pump it, it's going to work. And when you're done, it's not going to work. So it takes that stress away. And there are occasional patients who say, I'm a little numb at the tip, or when it curves, it bends a little bit, or they have a little pain. But most people are real happy with it. They really are. And the orgasm will occur. The feeling of an orgasm will still occur. So, yeah.
Are both these inserted into the penis?
Yeah, remember that slide where you saw there's 2 sides to the penis in the beginning? So each of those cylinders goes into each side, each corporal body. Yes. So that's literally the whole device. There's and the pump is easy to use.
They pour out
Right. When we do the procedure, we use what's called a Hager dilator. And remember that erectile tissue that you saw? We actually use this thing called a Hager dilator, we sequentially dilate it to make a space to put these in. So that's how we do that.
Is there different sizes?
Yes, everyone has different sized penises. So what we do is there's what we call rear tip extenders. The implants pretty much come in one size, but depending upon the length of one's penis, we put different extenders on it. And it also comes in different girths too, so the length of it can be different. And if you have a wider penis, if some guys, you can't get the bigger one and you need a smaller girth to it. But this is pretty standard for most men. But they're definitely something to consider. Medicare covers them. So they can rarely get infected and have to be removed, but that's not common, thankfully. It's pretty uncommon.
So once they're in, they can let the rest of your life kind of.
Absolutely, yeah. The only time we would ever take it out is if, in the unlikely event it got infected, or occasionally, like any mechanical device, there is a low risk, maybe 5%, that it'll rupture and leak. Leakage will not hurt you, but the thing will no longer work. It's all hydraulic pressure, so if it leaks, it's not going to get up anymore. Good, okay. So anyway, we sort of talked about all, and it's actually been, I said 1980s, so they say 40 years here. The inventor of this was a Dr. Scott from Texas. He died in a plane crash a few years after he developed it.
I mean, you installed it.
I don't do them anymore because there are certain people in town who really specialize in them. So I refer them to my colleagues. I think that I did a lot when I was younger, but now I do more incontinence work. And my feeling is if you're going to be putting these in, you should be putting in a lot of them. So I refer people to different colleagues for this who do a lot of them. Because, there can be little tricks to this. So, and sometimes after you've had radiation and prostate cancer surgery, you can get a lot of scar tissue. So I have 2 or 3 guys who do these all the time and do probably, 50 or 60 a year. And those are the ones I refer to.
I saw a movie about Forks Over Knives, a vegetarian movie. How much does the diet, like cheese and the milk, affect the erection as far as the blood flow to the penis?
Yeah, I've seen that movie. It's a good movie. Well, I think that, of course, even if you're a vegan and have a great cholesterol, if you've had prostate cancer surgery and your nerves are affected, it's not going to make that much of a difference. But for the average person who has not had prostate cancer and has not required prostate cancer treatment, I think it makes a huge difference. Because it's usually the arteriosclerosis, which causes the narrowing of the blood flow, or all those things you mentioned can raise your blood pressure more than a vegan type diet, and that can screw you up. So I think if you do all that stuff and you don't have prostate cancer, you're much less likely to have a problem. I think it makes a big difference.
Exercise is quite a bit too.
Absolutely, because you stimulate the blood flow when you do that. It really does. Yeah. So I was going to talk a little bit about, that's pretty much about erections. I was going to talk a little bit about incontinence as a result of surgery or radiation. Do we have that? I wonder how I can do that here. Maybe those guys could help me. I'll have to ask them. So you guys have any questions about erections? That's pretty much my little talk about erections. So the big new thing is going to be this chocolate lithotripsy and whether that pans out, which I hope we'll know. And I'm not trying to be vague. We just don't have the data yet. Yes.
I just read an article where they're saying it tends to become not effective after 2 years.
Yeah, what is not effective?
The acoustic wave therapy.
Oh, yeah. Yeah, maybe, yeah.
Where it decreases.
I've looked in the literature. I can find no good long-term data on it anywhere. So.
We did have a doctor here a few months ago. I think it was Dr. Green with it. And he talked about the shock treatment, and he said it was around $2,700 for 8 treatments.
Right.
I don't know if you know Dr. Green.
Yeah, sure. The question is whether it'll work long term. He doesn't know. No one knows the answer to that.
Right.
Yeah. So do you guys have the incontinence slides? Can you bring up those?
It's up there.
Oh, good. Okay, so I'll go through this a little bit quicker because I know we're running over, but just to help you guys go over this. So again, the same issues about who has it and what causes it. So, incontinence after prostate surgery is very distressing, or radiation for that matter. Now, the thing about the surgery that is important to mention is that many men who have robotic surgery, a good percentage will leak immediately after, but thankfully the great majority will get better. And the data that I've read suggests it takes about 9 or 10 months to really improve. And probably long-term, they say between 9 and 50% of men will leak a year after surgery. That's probably accurate. Of those men, only a very small percentage will be in diapers, where they're just leaking all the time. Most men will have stress incontinence. You leak when you swing a golf club, you pick up your grandkid, or you cough real hard, those kind of things. And it's distressing. And again, the anatomy, when we do the surgery, this is the bladder which stores the urine. The urethra goes through the prostate and comes out the penis. And this thing here that's around the urethra is a diagrammatic representation of what they call the sphincter muscle. And as you can see, the sphincter muscle is very close to the prostate. And the problem is that when we want to take out the whole prostate for cancer, we can damage the sphincter. I think robotics has made a huge difference because, again, the visualization is so good. So if you have a good robotic surgeon, the odds of it are very low. But I've seen it happen sporadically and with the best surgeon, and a case that went perfectly where someone just leaks. And I think one gentleman made the comment, I think you did, sir, that some people just have different physiology, that unfortunately, even when things go really well, there can be someone who leaks. Leakage is, it's not just prostate cancer surgery, but radiation can do it too. Now, even though with radiation, no nerves or blood vessels are being cut, you're really destroying the prostate because you're getting rid of all the cancer. So radiation destroys the prostate, but it's also going to destroy blood vessels and nerves that are adjacent to the prostate. And those are the blood vessels and nerves that not only help with your erections, but they help with your control. Because and the sphincter muscle can get fibrotic from the radiation. So radiation, unfortunately, can do it too. Neurologic disorders, but neurologic disorders cause more urgency incontinence. Like if you've had a stroke or you've had Parkinson's, you're probably going to leak more because you can't get to the bathroom, and not really with coughing and sneezing, or bending, which is what we see more from prostate surgery. But then, we can help that too, but that's another issue. So just a little thing, as I was saying before, I find that incontinence really detracts from people's quality of life in so many ways. They're embarrassed to go out, they're embarrassed to play tennis or exercise, which can detract from your health. They're emotionally, it can cause depression, it can be expensive because it can, you have to buy all these diapers and pads, and it really is a big deal. So to help it for most people is worth doing.
Excuse me.
Yes.
On the sphincter muscles, are there exercises you can do to strengthen?
Absolutely, that's a very good point. In women, they're called Kegel exercises, and they really can work. Like any exercise, they take time to strengthen your muscles. You're not going to go out and play golf like a pro one day, but they involve squeezing and relaxing your whole pelvic floor. I always tell people, think of it like you're trying to stop yourself from having a bowel movement, because then you'll squeeze your whole pelvic floor, which involves not only your rectal muscles, but your urinary muscles. So you squeeze it, hold it, relax, squeeze it, hold it, relax.
How long would you hold?
A few seconds, 2 or 3 seconds, just
So
go.
then relax, and then just a couple seconds on.
Yes.
And both you call it what for?
Well, the easiest way, pelvic floor, which is your whole body. And I think you do a better job of squeezing your whole pelvic floor when you think of it like you're trying to stop yourself from having a bowel movement. Because you think of it more of trying to stop your urination, people tend to squeeze the muscles up here. So I think you can focus on your bowel movement squeezing and do it 20 times in a row, 2 or 3 times a day. Hold it for a few seconds each time. Over the course of 2 or 3 months, you can really improve. Yes, sir.
I just want to, say that's very true, because if you graph it out and do it often enough in any particular day, you can basically take care of all your incontinence problems with those capable exercises. They're excellent.
Yeah,
But you need to learn how to isolate so you're not using your thigh muscles and your stomach muscles.
right.
You really gotta shift down the chair and find that muscle, that floor, the pelvic floor muscles to work on just then. Make sure you're not, because if you're working other muscles, it doesn't work. They really are ideal.
Yeah, we have a nurse in our office who we also often have the fellows meet with, and she can work with them and really show them how to isolate those muscles. If some folks-
Greg, I have this thing on my phone I shared with you guys a few months ago. It's called Kegel Camp.
Oh, okay.
It's phenomenal.
Really? Kegel
I'm
camp?
up to number 15. I'll just show you real quick. Start. Ready? Say 10. But this is level 15 already. It'll tell you relax. All right, I won't waste more of your time. But it's a fantastic app.
Sounds great.
And you
Yeah.
go, so it starts level 1. I'm at level 15, and you just work your way up. And it's a fabulous.
Yes, sir.
Also, I had the surgery in January,
Mm-hmm.
and I'm going to a physical therapist,
Mhm.
which is paid for by
Sure.
Medicare.
Sure.
So,
Yeah, that's another thing. We do have physical therapists, and they have them here at the hospital. They're very good. We've often, if we write a script, I believe it's covered. And right?
yes, it is.
Yeah. Yes, sir.
In Venice, I don't remember her name, but in Venice, there is a pelvic floor rehabilitation person.
Yeah, she's a Russian woman. I forget her name too, but I think we have her in our office. She's very, is that the one you're talking about? A
I don't
Russian?
think she's Russian.
Okay.
She was put in on the Sun paper. But her name is like Green or whatever. And she specializes in urinary incontinence. And there's some special, as this gentleman was saying, there's special technique that you have to do to isolate that muscle, that Kegel muscle. And one of the ones that I had taken was that when you pull in, like stopping the bowel, you're supposed to visualize that you're pulling in towards your navel, because it's a way to isolate that muscles a lot better than just tightening.
What's that? You want to hold in Europe.
Yeah, I think if you,
Where you can't go. You have to hold it in. So you,
yeah, but if you focus more on your bowel movement and how you would stop that, I think you're much more likely to be isolating the proper muscle. That's what I always tell people. I mean, you could always see one of our therapists or a physical therapist, but just to do it on your own, that's the best way to think of it. To use the right muscle.
I'm thinking maybe it would be wise for us at some point to bring somebody in that could do an
Right.
exercise.
Yeah, we have a very nice nurse in our office who would be great. She could, I'm sure she'd be happy to come over sometime.
What do you think? That might be worth doing.
Sure.
Yeah, she's really great at it. Yeah.
Very significant.
Yeah.
Yeah. Yes, sir.
You talked down here about this. What about the bowel movement after radiation? There's instance of mucus and sort of a small diarrhea that's hard to control.
Right, right. I'm not, because I'm a urologist, I'm more of a front end guy. So that is a good question. I don't really know. No, really. I mean, it's sort of like that's a back end problem. I'm not an expert on that. I usually, I use things like Lamodal, but I often will refer someone, frankly, to a gastroenterologist because that's more their area than mine. But that is a big problem as well for some people. Yeah.
Do you know what they've done about that?
Yeah, they usually use, they have certain suppositories they use. I'm sorry, I'm blanking on the name because it's just not really my expertise. But they do have some suppositories. They use Lamodal, I know. They make certain dietary things like, changing your diet, maybe more fiber or something like that to try to bind up the mucus. And they can help a lot of people. They really can. But I'm just not my expertise on the back end. I'm sorry. Yes.
Is most of this urinary incontinence and erectile dysfunction occur right after surgery or shortly after?
Yes, they both occur right after, and they both hopefully in many cases get better and better.
Yeah.
But it's not like in other words, if you're 2 weeks out or 3 weeks out and you're golden with everything, you're going to be fine.
So 5 years down the road, you're not likely to see.
Correct. And everything gets better. It happens right away and then it gets better. Yes.
Unless you have radiation. Just radiation.
Yeah, oh yeah, he asked about, I think he meant surgery, right?
No, I was talking
Oh,
about
I'm sorry.
any treatment.
Yeah, no,
Radiation.
yeah, I'm sorry. You're right. I thought you meant just surgery.
Yeah.
With radiation, you can have problems later on. That is true. Because I'm sorry, I misunderstood your question. Yeah, radiation unfortunately can have problems anytime during your lifetime. It can develop. Even if you're 10 years out, the tissue is, is friable. Blood vessels can break and bleed years later. And even incontinence, because of progressive scarring, can develop years later. So radiation is different. Yes. Yes. Yes.
So are you talking about beam radiation, or does that apply to seeds and everything else?
I was talking generically about any kind of radiation, because really they do the same thing. I mean, there are differences. There's the old-fashioned proton therapy that was great years ago. Now there's the IGRT, the interstitial guided radiation therapy. Used to be brachytherapy. Now there's high dose, the HRT, the high dose radiation therapy. So there's all different, HDR, excuse me, high dose radiation therapy. They're all basically doing the same thing, which is destroying the tissue with radiation energy. So they all really have the same effect. You can argue there's, we're a little bit better nowadays with it, and there are subtle differences that give people less side effects, but they're really all doing the same thing. The big change with radiation, just to mention one thing, is that we're now much more precise where it goes. We're able to define with the modern imaging techniques. So there's less scatter to the organs around the prostate. You don't want to radiate your bladder, your small intestine, your urethra, because they don't have any cancer. So our newer techniques are much better at reducing the scatter. So that's why there's less side effect nowadays with radiation. But it still happens, unfortunately.
Well, I think we're getting close to 3 o'clock. I know if
Sure.
you're willing to stick around for a minute or two, maybe after we close, you have other questions for Dr. Bragg.
I just want to do one more thing real quick, and then that's okay. We'll finish up. I just want to mention about our surgical treatments for stress incontinence. And there really are 2 of them, just because we're talking about gadgets today. The 2 things we do for surgery. Now, these are for men in whom they have stress incontinence after surgery, or for that matter, after radiation, where they're leaking a lot with stress incontinence. And we always wait about a year to make sure it's not going to get better on its own. And the 2 things we do are called male slings and artificial urinary sphincter. You didn't bring a sling in, did you? No, it's okay. A sling is a small piece of mesh that, and you heard of slings in women. They're very common in women. And in fact, there's been a lot of problems in women. The FDA has put all kinds of advisories. But in men, the sling is a small piece of mesh that is surgically implanted under the urethra. It helps mild leakage. I personally am not a fan of them. I found that they don't work that well. Some urologists do them. And my gestalt on it is, if you have mild leakage where you're wearing maybe 1 or at most 2 pads a day and you haven't had radiation, it can work okay for that patient. But most of the patients I see are well beyond that, and they want something that's going to really work. And I use the sphincter a lot. The sphincter is a mechanical device, and it works very well. It's a minor operation. Haley, I think, has one here. It's the same principle as the implant, where it has a pump and it has a fluid reservoir that goes under the skin, and it has what we call a cuff. Let me see if I have a picture of it. I forget if there's a picture of it. We don't have a picture, but she's passing it around. There's a part that goes around the urethra that keeps it closed off so you don't leak. And then when you want to pee, you squeeze this pump next to your testicle, concealed under the skin, and that opens it up for 2 minutes and allows you to pee. And then it automatically will close up. They can occasionally get infected. They can occasionally leak, like the penile implant, but for many men, they're really a godsend and work well. So for guys who are really suffering from it, I think it's a really nice surgical solution. All right, so I'm going to stop here because it's 3 o'clock. I hope that was helpful for you guys. And any questions I can answer, feel free. Thanks. Yeah, thank you, Haley. Thank you for coming in. Haley brought all the stuff. Thank you.
That was a terrific explanation for a lot of details that
Well,
most of us
thanks.
have not addressed very, very effectively.
And I'd be happy to talk to Linda in my office if you
Yes,
want to.
yeah,
Just
I'll
email me
follow
or
up
something, or
with you.
text me.
I
or
think that would be great.
I just want to make, we're really happy the doctors will come in and talk to us.
Sure.
It's wonderful.
Well, thank you. Thank you very much.
It really is a
It really
pleasure.
makes
Thank
me
you.
feel
Thank
good
you.
about the Sarasota Memorial group of physicians.
Well, thank you.
guys who are big.
Thank you.
I think we all share that sentiment for sure. Well, thanks very much,
Okay,
guys.
thank you.
Is there anything else? I've got a couple of quick announcements I want
Yes.
to
Have
make.
you ever heard of the
First of all,
E3?
next month, we are gonna meet. At the 17th at 2 o'clock.
No, sir, I haven't heard of
You're
that.
all welcome to come. I'll
It's
send out
two.
notices as I normally do.
I had the surgery in January.
We are
My
also
problem
having
is I
a
don't get
small group
much
today at
notice.
3:30.
Not enough
Any of
notice.
you are welcome to join.
And this
Just
is
general
supposedly some kind of
conversation, and
prediction
questions and
device that
answers about any
give you
issues
an
you
alert
may be
that
facing.
your bladder's full
And
and
it's,
you need to
we're
go.
gonna close
No,
off
I
the
haven't
door
heard
and
that.
have a
Sorry,
little
I don't
private
know.
space here, so you're welcome to join us for that. Then there are a couple of books I wanted to point out to you that we have available. I've got available, actually Steve Gordon, who's sitting right here, is head of the US2 program in Sarasota, was kind enough to bring me a copy of this, which I didn't have until today. And then there's another, this one is called the Prostate Cancer Patient Guide, and it's done by Prostate Cancer Foundation. This one is the 2019 Prostate Disease Annual Report done by Harvard. We have both of these and I can lend them out to you. I don't have a lot of extra copies. This one,
have it electronically.
this one I have electronically and I can produce it for you. So just let me know if you need either one of them. These two copies. Pardon me?
Can you give us a link to that when you send out your email?
Yes, yes. Yes, I will do that. Yeah.
I'm sorry, he was looking to see from
Oh.
What's that? Oh, yeah, no, I was looking for a second, yeah.
Yeah, this is one that just come to our attention recently.
That's very nice, yeah, excellent.
And this one.
Sure, from Harvard,
Stan,
yeah.
I had the rest of this.
Cool, that's great.
Interesting information. There's a ton of information out there. Now, the last quick thing is I've asked Alice Hicks, or Alice Hicks has asked me.
Thank you.
Alice
You're
runs the
welcome. Thank
Thrive
you.
Oncology program here at Sarasota Memorial Hospital. This is something that has come across to me only recently, and that's probably my own naivete. But Thrive Oncology is an attempt by the hospital to really pull together a lot of cancer